Hey guys. All right, guys. I'll start here in a second. I was just trying to see if other people would show up, so like they're supposed to here. All right. So on our lab schedule, so for the last few weeks, like we were supposed to talk about central line dressing change. We were supposed to talk about parenteral nutrition and also like trach suctioning. So I just wanted to kind of review a little bit of stuff with that stuff. So when we do a central line dressing change, so like I don't know, just picture, your patient has a dressing like right here in their neck and it's a central line. So when you go to change that, usually, hopefully, at your facility you will have a central line dressing kit that you just grab that has pretty much everything you need in it. So you would go get that, and when you go to change this, you want to have a mask on and you want your patient to have a mask on as well. So you sometimes, like, the kit doesn't include more than one mask, so you would have to grab an extra mask to bring with you. When you change the old dressing, you're going to get, clean gloves first to take the old dressing off. And then you're going to ball that up in your hand after you get it off. And then you're going to remove your old gloves and throw it away with your old gloves. Then you're going to have your central line dressing kit open, and in there you should have um, like sterile gloves to put on. So you're going to put your sterile gloves on, and inside the kit you should also have something to clean the central line with. So whenever we change the dressing, usually we clean it with like some kind of chlorhexidine or something. So what I've seen typically in these kits has been like a long stick thing that it has like little wings on it that you crack the wings, and it puts all of that chlorhexidine in the little sponge thing on it. And then you just clean off the site and you do like large circles with that. And you do that for about a minute and you clean the whole thing. So you clean like the area where it goes in at, and you can even clean onto the central line itself, like onto the ports and everything. So you let that dry for a good minute. And then we have something called a biopatch. A biopatch is this little round, like spongy thing that you're going to put right by the skin, right where that goes in at. So you're going to put that under there after you've cleaned. This biopatch has chlorhexidine in it, So as it sits there for a week, because you're supposed to change these dressings every week, once a week, um, it will let out a little bit of chlorhexidine throughout that time period, so it'll like keep germs away. So it's kind of a good thing to have there. So then after you get that placed, then all you have to do is put your occlusive dressing over top. So you should have an occlusive dressing there in your kit. You take that off, put it on there, and then it should have some kind of thing where you can label with. Usually there's a little thing you rip off and you put it on there to label. So you're going to label with your name, the date, um, yeah, just the name and date. There's time, I guess, if you want to put time there. So it's pretty easy, though, to change a central line dressing. So I want to make sure everyone's clear on how to do that. So if you were doing a PICC line dressing change, that would be a little different than one that's in the neck here. A PICC line, usually it's in your upper arm, and when they put those in, sometimes they'll use I think of the name of it. It's like a stat lock. So it's like a sticker that you put on the skin, and then it has these little plastic things that come up over top and close down onto it to keep it steady, so you can't pull it out or anything. So the PICC line might have that. So you would not have that for the other types of central lines, only this one. So if you did have that, when you're changing the dressing, you would change that as well and put a new one of those on there. And this will make more sense when we're at the school and we can actually practice this stuff and I can show you what the heck I'm talking about. So just be aware that, again, I'm going to say it one more time, the steps to doing this. So central line dressing change. You are grabbing your central line dressing change kit out of your clean utility room. You are also grabbing an extra mask. You are going to have a mask on and your patient's going to have a mask on. For you to change this dressing, you can put clean gloves on first to take the old dressing off. So you're going to take that off, you're going to ball it up in your hand, and then you're going to take your gloves off with it, throw that stuff away. Then you're going to you're going to wash your hands, and then you're going to put your clean gloves on, or your sterile gloves that come in your kit. So now you're sterile for the rest of the procedure. So everything that's in that kit should be what you need. So the next thing you do is you're going to clean the site, and typically it's going to be with a chlorhexidine swab that they have in there. So depending on what type of swab in your kit, whatever. So you're going to clean that, and you do large circles around where it goes in at, and then also you can even go onto the central line itself. So you can clean all of that. It gets it nice and wet, and so you leave it dry for at least a minute before you do anything else. Then once that's dry, then you're going to pick up your BioPatch. That BioPatch is a small little disc that you put around the site where it goes in at. And this is impregnated with chlorhexidine as well. So over time, as it sits there on their skin, it'll kind of help keep germs away as well. So after the BioPatch is put on, then all you need to do is put your occlusive dressing on over that. So typically it's like some type of Tegaderm type of a dressing that you put over top. And then you would label at the end. And you always want to make sure you don't have any air getting in under there. So make sure it's nice and secure, that you don't have any issues. Does that make sense? Yes, no? Someone talk to me.
Yeah, it does.
Yes.
So central line. So when we go back to school, you guys will come with me on Fridays. The first couple weeks in August, we're going to go and we're going to practice this stuff first. And then probably the next week and the next week, we'll go ahead and mark off. So don't worry, because it'll make more sense when we're there and you can see everything. Okay? So that's one of the things that we're going to do, is that central line dressing change for a checkoff that we'll do. One of the other things on our schedule here that we were supposed to talk about is parenteral nutrition. So this would be TPN. So TPN, when you give this to someone, this is in a humongous bag, so really big. So I don't know, it could hold up to almost 3,000 milliliters of fluid. It's huge. So this has a bunch of stuff in it. So all of these different things that make up TPN, it is just supposed to be like a nutrition type thing that you do for a patient who can't get like tube feed or anything else for some reason or another. All right. Anyway, so when you get this bag, when you have an order for this, typically there's a specific time of day that you change it. And where I worked at Summa, they always did it at 6 p.m. So every 6 p.m. you would go in, you would get rid of the old bag, you'd put the new bag up. So it would hang for 24 hours, right? And so every time you change bags, you always change your tubing. Everyone mute yourself, please. Anyway, every time you change the bag, you also change the tubing. So you always have to get new tubing every time. And then when this comes up from pharmacy to you, it should come with a certain filter that you're going to put on it. They give it to you, so you don't even have to worry about it. So when you put your primary tubing on there, then you're also going to hook up that that thing that the pharmacy gives you to put on the end of the primary tubing, you know, your filter. So that filter will hook up to the patient itself. All right, so this big thing of TPN, when you get this from the pharmacy, you as the nurse are supposed to go grab another RN to check the orders with you. So one of you has to be on the computer looking at everything that's in it. The other person also has to be checking it on the bag, because on the bag they'll have like a paper plastic thing there that lists everything that's in there. So someone's looking on the computer, someone's looking at the bag. So as I'm reading everything off, this person would be checking it off, making sure everything's in there. So if something's not in there that's ordered, then that's a problem. So you need to let someone know. So you would call the physician and tell them that, hey, they sent me this bag. It doesn't have potassium in it today. What would you like me to do? You know, chances are you're not going to get that fixed that evening, because typically most places get their TPN made somewhere off site and they don't make it there. So they can't send you a new bag. So you would just have to see what your physician wants you to do. So if he still wants you to hang it, you would still hang it, but you know, maybe they'd be missing something. But you would have to document this, that you call the physician about it and you notice this, you know, you would have to put that in your notes. So anyway, again, there's real specific stuff that's in this bag. So usually people who get TPN are someone who can't get tube feed and they can't get oral nutrition for some reason. So the TPN itself is going to help them a little bit with their nutrition, but it's not optimal. So obviously we would love to just be able to give them oral things, because that's going to give them better nutrition than anything. The next best thing would be tube feed, but for some reason, whatever is going on with this person, they're not able to get that. So this would be the next best thing. So this is going to go through the IV, this feeding that you're giving them. So anyway, so when it's time to hang a new bag, you are going to check the order with that person. Once you know everything is good, you're going to go in there, you're going to get rid of the old bag and the old tubing. Even if the old bag still has like this much fluid in it, you're still getting rid of it. You do not want to still infuse that. A lot of people don't like to waste stuff, so they're like, oh, I'm just going to give the rest of this, you know? But that's not good. It's been sitting for 24 hours up, and it could have bacteria in it at this point, so you don't want to continue that. You're going to get rid of it. So this stuff in the TPN, it has dextrose in it. And so you can have bacteria grow in that really easily after a certain period of time. That's why it's only up for 24 hours. The other thing, when you hang this, you want to make sure that you label your tubing, because your tubing you should always have labels on everything. Even though you're going to change it the next day, you still want to label everything. You also want to label your bag. When you check the bag with that other person, both of you are supposed to sign it with your initials to say that, yes, I did check this. All right, so then once this new stuff is up and you've gotten rid of the old, then you're good to go. So this person has this up for the whole evening and then until the next day at that same time. Now, there is some TPN that is ordered differently where it's like a cycled kind of a thing. So if you have an order for a cycled TPN, then sometimes your physician will tell you to start it at that, the time that you start it at a certain rate. So like maybe, for example, maybe I'd started at 50 milliliters an hour. So then the next hour, I would turn it up to like 75 milliliters an hour. Like it'll say in my orders what it wants me to cycle it up to. And then the next hour, maybe I'd go up to 125 an hour. And then I might leave it there for so many hours. And then I would cycle it down again when it's almost time to get rid of it. So then I'd go down to 75, go down to 50, and then I'd shut it off. So that's cycling. So you have to pay attention to your orders if you have that ordered. Sometimes when people are on TPN, if they are starting to do better, it's not uncommon to see someone on TPN and on like oral food. Like maybe they're not taking in enough nutrition orally to be able to sustain themselves, and that's why they're on both right now. So once they start taking in more by mouth, then they can get rid of the TPN. Okay? So one thing that is a complication of TPN is that it can affect your blood sugars. So if a person that you're giving it to is not diabetic and they're wondering why you're checking their blood sugars, that's why. Because this fluid that you're giving them has dextrose in it, and it's going to affect their blood sugars. So especially when you first started on someone, you're ordered to check their blood sugars, AC and HS, which means, before meals and at bedtime. Now, some people will just do it every 6 hours too. It depends on how it's ordered. Now, after those first few days, if their blood sugars have remained stable, sometimes the physician will let you discontinue doing that. And then you'll still get labs that you have ordered every day, and you'll still be able to kind of monitor it that way. So that way you wouldn't have to keep doing these blood sugar checks on them. Now, every day that this person is on this TPN, there's labs that you have to draw in the morning. And so some of the labs would include like a CBC and a CMP, which is going to show you like their whole thing of electrolytes and everything. There's also, you have to monitor their lipid level as well, because this bag of fluid can actually affect that as well. So you're looking at that. You're checking their liver enzymes and different things along those lines. So there's a bunch of labs that you have to draw. So every morning when you look at the labs, you can tell if there's something that needs fixed or not. The nice thing about TPN is that, like say someone is low in potassium, well, you could add it to their TPN, and then it would be a lot tolerable for them, more tolerable that way than it would be taking it any other way. So if I was giving it IV form, like peripherally, it would hurt. But if I'm giving it in the TPN, anyone who gets TPN has to have a central line. So if you have a central line, that means it's like a bigger bore IV, so you can tolerate things a lot better through that. So that's kind of nice. You can add things that way. Same with blood sugars. Like if you can tell that this person's having issues with their blood sugar, you can add insulin to this. So you can add certain things to it to help fix other problems. So it's kind of nice that way. Make sense?
Yeah.
Okay. All right, so when we are at campus, we don't really have like a TPN bag or anything, but we'll talk through all of that again just to make sure you're aware of what you're doing with that. Now, the other thing was tracheal suctioning. So we need to talk about that for a minute. So did you guys do that last term at all when you were in intro to clinical nursing?
We just did it this Wednesday.
You did it. Okay.
We
So,
saw it. We haven't checked off yet, but
okay. So when you suction someone through their trach, take me through the steps on what you're supposed to do. Someone tell me. What supplies are we getting together for this?
Um, wouldn't you need like gauze pads first, because you'd want to, like, when you were done cleaning, obviously you need the gauze pads to clean and to keep if they need it. You'd need a
Yeah, but we're not really talking about like the trach care. We're talking about just suction.
so then you'd need the suction. You'd need the suction canister. Um, would you need a new tie, or only if it was dirty? Just
Well,
have it in case.
typically when you do trach suctioning, usually you make a mess with that, so you always would do trach care right afterwards, and you would change ties and do all of that. You know.
Okay. Hmm.
So
Then
go ahead.
um, I can't remember what else you'd need.
So the kit that you get, there's a little kit. There's a specific kit that you would get out of your clean utility room. It has that red rubber catheter kind of a thing, which I don't know if ours at the school look like that or not. I can't remember, but it has that little red rubber catheter, and then it also has like a little box that you put together, and then you would have saline that you would pour in that box, right? And this is
Hmm.
a sterile procedure that you'd be doing because this comes with sterile gloves
Yeah.
in that kit. So the red rubber thing that comes in that kit, you would attach to your suction tubing that you would already have at the bedside, right? So you would have your canister there, you would have your long suction tubing, and that would be hooked onto the end of it.
Hmm.
So you would have to get like a bottle of normal saline to bring in with you so that you could pour that into that little box that you put together, right? And so when you get ready to suction someone, you remember that little red rubber catheter has that spot where you put your thumb over it. And as you're putting your thumb over it, you're that's giving you the suction basically, right? When you put your thumb over it. So before you suction, you are going to put a little bit of saline through this, like suck some saline up through it so it's nice and wet and your suction is working okay. And then if this person needs pre-oxygenated, maybe you do that first, right?
Hmm.
Because when we suction, we're essentially kind of taking their air away from them for a little bit. So it can be kind of distressing, right?
Yeah.
So maybe we pre-oxygenate for a few minutes before we start. And then we take that away. And then when we put the red rubber catheter in there, how do we know how far to go?
Um,
um,
don't you measure? I forgot what you measure, because she said not to. She said some nurses just put it in until you meet resistance, but that's not always good because you can damage the inside.
yeah.
What were you going to say, Gloria?
Does it come with like the order comes with how far you should go in?
No.
No.
Mm-mm. Anyone else have a thought? So the catheter itself, you've seen what it looks like. It's not like super, super long. So, you can imagine when you look at someone's throat, like say, here's where my trach is or whatever. So as I'm going down, I don't want to go down super far, right? So I'm going to go down, I always was taught till I met resistance too, honestly. So I would go down just a little ways, and you know, once you're down a certain amount, this person's going to start coughing anyway. So as they're coughing, you are going to put your thumb over that little thing, and you're going to kind of like move the tubing around as you take it out, right? And you're not going to do this super slow either, because the slower you do it, the more, you know, problems this person's going to have, right? So you're going to kind of move the tubing around as you come out, and you have your thumb over it as you're coming out, so you're sucking all that junk out. When you come out, you put the oxygen back on the patient, let them relax a few minutes, right? And I think in the reading and stuff, they always say to have a pulse ox on the patient too during this whole thing, to make sure you're monitoring that that's doing okay during the procedure. What else did she tell you?
So pretty much there is not a way of measuring it based on what you're saying.
Yeah, I was never taught,
Okay.
to measure a certain amount or anything. No, I'm just trying to get from you guys to know that you don't have to put it like all the way down. There's no way, you really don't have that far to go. So there's just a little ways that you would go, and you're going to know by looking at the patient if you're down far enough or not, and by hearing what they sound like. Because typically when someone needs suctioned, you can hear them without even putting your stethoscope on them. You hear all of that junk there. So after you suction, if after they calm down a little bit, if you still hear a lot of junk, then you might need to go down again, right? And usually the patient can tell you if they still need to be suctioned more or not. So anyway, this usually will help get some of that stuff out. They'll feel a little bit better. And so some people you need to suction like frequently, and some people you just do occasionally. So it just depends on the person and what they have going on. But the big thing is, to make sure that when you put the catheter down, that you don't have your thumb on that thing. You don't want suction when you put it down. You just want it when you're coming out. So remember, we have a test question on this particular skill. So that test question, so you're putting everything in the right order of what to do. So some of the things that they list, there's like 6 different things, okay? So they list set up the wall suction, check the function of the suction catheter, apply sterile gloves and designate one hand as contaminated, insert the catheter without suction, apply intermittent suction while rotating the catheter, and then hyperoxygenate the client. So what do you think would be the right order for those? Now
The oxygen would come first, right?
Oh, go ahead. What would you say?
The oxygen would come first.
The pre-oxygenate?
Yeah.
Okay. And I have seen that done both like before you start and at the end too, to hyperoxygenate them again. So I have seen it done both times. So after you hyperoxygenate, what would you do next? Would you set up the wall suction, or check the function of the suction catheter, or apply sterile gloves?
Set up the wall suction.
Okay. What would you do after you put the wall suction up? So would we check the function of the
Application.
catheter? Would we apply sterile gloves? Would
Apply
we,
sterile gloves.
yeah, so the sterile gloves would come next. And then you would check the function of the suction catheter because you already have your sterile gloves on and that is sterile, right?
Yeah.
So after you've checked the function of the suction catheter, then you can insert the catheter without suction. And then you would apply intermittent suction while rotating the catheter as you're trying to get all that junk out. Make sense?
Yeah.
Okay. All right, so that's that. And that's something that we'll practice too when we're at school together. We'll just do that together and make sure you're good there. So you'll essentially, if you're doing it now for your other, the other class, you'll get it again as well. All right, and then there on our thing too, when it talks about chest tubes, the one thing that we would do as far as a skill with chest tubes would just be a chest tube dressing change. So those are no big deal at all, so don't even worry about it. But basically, let me see if I can talk you through it. So what we would do is we would get some 4x4s, so those 4x4 gauzes, right? And you know how sometimes they'll have like a boat of them where there's a ton of them? I would just get one of those, right? So you have a lot of them. I would also get one of the drain sponges. So you know how there's a drain sponge that's a 4x4 with a slit in it? I would get those. So you would grab a pack of that. And then I would get, if there's, because really they don't have like a chest tube dressing kit or anything. So you just have to get everything separate. So then you would get like a chlorhexidine swab. So you have something to clean with. You would get that. There is a Vaseline gauze that you would get. So that comes in its own little package. So you grab that. And then just tape. Oh, skin prep too. You would get some skin prep. So you get all that out of your clean utility room. You come to the bedside. Again, you can do clean gloves to take off the old dressing. Okay. So I would do that, put my clean gloves on, take off the old dressing, and then I would throw that stuff away, wash my hands, and then I would put my sterile gloves on. So you would have to grab sterile gloves too for this, I guess. So you would have everything open already, so you don't have to fuss with that. And then one of the first things you're going to do is use your skin prep. So the skin prep is just going to go like along the edges of where the dressing's going to be at. So we use a lot of tape for these dressings, and a lot of times people's skin gets all messed up from that tape. So using that skin prep kind of helps so that, I don't know, it kind of like toughens up your skin so you don't have so much trouble there. So if you just like kind of paint the edges of where the dressing would be at with that skin prep, that helps. So that's the first thing. The next thing you would do is you would take that chlorhexidine swab thing that you got, and you would clean around where the chest tube goes in. So you would do some big circles around that. And then you let that dry for a good minute. Then you're going to get your Vaseline gauze. So the Vaseline gauze, when you open up that package, it's usually folded in on itself, and if you unfolded it, it'd be like really long. So it's like a white dressing that's like full of Vaseline. It's really like, it feels just like Vaseline. So you can unfold that, take it out, and then you're going to wrap it around your chest tube where it goes in at. And you're going to push it down by the skin. So it's just going to be bunched up around the chest tube site, right down by the skin. So then the next step would be to get your drain sponges. So when you open up a thing of drain sponges, usually there's 2 of them in a pack. So you would put one this way, the chest tube's right here. And then I would take a couple of those 4x4s from that boat that I got, and I would put those on top of the chest tube. So that's the dressing. And then all you do is tape. And you tape it in such a way that it's going to be occlusive, that you have no air that gets under there. And I'll show you that when we're at campus. That's not too big of a deal. But that's all you do. It's really simple. So that's one of our skills that we'll do as well. So really, like the things that we'll do at campus, we're going to do IV starts. We're going to do practice blood draws. So both of those two things. So that'll be a check off. We are also going to do some stuff with the IV pumps, you know, so I'll be like, hey, this is how you do a primary. This is how you do a secondary. Show me how you do this. And you'll show me those. So that kind of stuff. And then we will also do the central line dressing change. We will also learn how to do the, you know how when we talked about central lines, we talked about med ports being one of those types. So we have like this chest or chest thing at the campus that we can practice doing the accessing and deaccessing a med port. So that's another thing we'll do. And then just this trach suctioning, we'll do that. And then we'll talk through that parenteral nutrition. I don't think there's a whole lot else. We'll talk about like blood products. That's something we do next week. So that's another thing we can just kind of talk through there. And then I think the only other thing they have listed on here is ostomy stuff, but that should just be like a review for you guys. So that's kind of our skills that we're going to be doing. All right, real quick, do you guys have like paper and a pencil that you can do a couple math problems with me real quick? So on our next test, we are going to have 5 math problems. Why 5? I have no idea, but we have 5. So let's see if I can find them here. Okay, so one of these problems is just going to show a syringe. And it's going to say the nurse is administering a prescribed regular insulin to a client with diabetes. Using the graphic shown below, how many units of insulin has the nurse drawn into the syringe? So like you're going to look at it and it's going to show you a certain amount and you're going to say, oh, that's 5 or that's 10 or that's 15 units or whatever. And that's going to be your answer. That's all that one is. Have you ever looked at that kind of stuff before?
I think so.
Okay, because I know, I mean, we haven't really had a question like that before, so hopefully it'll be no big deal to you. But from looking at this, I think it should be no problem for you to be able to figure out how much this is. Okay, the next one. The next one is going to be this. So we have a medication that's 500 milligrams. It's ordered, it says the nurse is administering a prescribed medication, 500 milligrams by mouth, twice a day to a client with diabetes. The nurse has 500 milligram tablets available. So how many tablets should the nurse administer? Geez, you don't even need to write that down. How many would you give? If you have
1.
if you have 500 and you're supposed to be giving 500, you're going to give 1. So not rocket science. So 2 easy ones right there, right? So then we have this one. So again, another simple one, which probably you could figure out in your head. So we're administering a medication that's 12.5 milligrams by mouth 3 times a day to someone with hypertension. What we have on hand is 25 milligram tablets. So how many tablets should you administer with each dose?
2.
What's that?
2.
Not 2.
What was the question?
Can you repeat it? Can you
Yeah.
repeat the question?
Yeah. So the order is for 12.5 milligrams of a certain medication. All right. And you're supposed to give it 3 times a day. The nurse has 25 milligram tablets. So how many tablets would you give for each administration of that med? It's
Because I don't get that question at all.
well, here. Let me do this. It's hard because you can't see what the heck I'm talking about. That's what the problem is.
Is it 1.5?
No. Okay, so remember, we put what's ordered on the one side. So 12.5 milligrams. And then we put on this side what we have on hand, 25. So 12.5 is half of 25, isn't it? So if I'm giving one tablet as 25 milligrams, I'm only going to give a half a tab if this is what's ordered, right?
Oh, so the question was per each I thought it was for the whole day, like the whole day. How many milligrams are you giving?
It's not asking for the whole day. It's asking every time you give a dose, how much would you give? Yeah.
It is 0.5, yes.
Okay. So that's that one. So another not too bad one. Then we have an order for 300 milligrams. Let's see if I can draw this without making a mess here. IV that we give every 6 hours for someone with a respiratory infection. So this is what our order is for, 300 milligrams. And what we have is 300 milligrams. Can't believe how simple some of these are. In 50 milliliters. So how many milliliters are we giving? 50 milliliters, right? So 300 is to 300 as 50 is to 50. It's going to be the same thing, 50. Make sense?
Tell me, question that one again. The 300.
It just says, so you are administering a prescribed medication that's 300 milligrams. And it's ordered for every 6 hours. But that every 6 hours doesn't matter here. The nurse has 300 milligrams and 50 milliliters available. So it's saying you should set your infusion pump for how many milliliters per hour. It's going to be 50, right?
Yeah.
Yeah.
Okay. All right, so then the very last one, let me erase this bottom one here. This one's a little bit more difficult, I think, so let's see if we can figure it out. Okay, this one says we're administering a medication that is 2 milligrams per kilogram. Let's see. And it's given IV every 4 hours for a client with status asthmaticus. And this person weighs 188 pounds. It says the nurse has, this is what she has available. She has 80, geez, I can't write with this, milligrams per milliliter available. So how many milliliters should you administer with each dose? So always, we should always start with the weight, right? So if we want to change that to kilograms, what would that be? So something like
5.
85.45 repeating, right? So if we want to take that and put it here, right? Because this is just kilograms, so 2 milligrams would be that over that many kilograms. What are you guys getting?
For the weight multiplied by 2 milligrams, like I got 170.9.
Okay. And then what do you do from there?
The answer is supposed to be in milligram or milliliters. Which one?
It's just asking for how many milliliters should you administer with each dose. It's just asking for milliliters only. And it has to be rounded to the 10th place.
Oh.
Okay, so anyway, this was, you know, like 85.45 repeating, right? So it kept repeating this 4-5. So once you get this, you would multiply that by your 2, right? So whatever you get here, you multiply by this. And then, let's just say this, 85.45 times 2. And then you said you got like 170.
0.9.
0.9090.
Yes.
Okay, so then from there, we're going to take this, because remember, this 85 point whatever was in kilograms, and so the kilograms cancel out. So this here, this 170.9090, is in milligrams. So that's what we're going to put here. Jeez, I can't write with this.
Maybe like 2 point something milliliters.
Okay, so then you would take your 170, if you do it this way like I do, and I don't mean to screw anyone up, but 170.9090 times 1 is 170.9090, and then you take that and divide by 80, and you get 2.1363 repeating. So the answer wants it to be to the 10th place. So the answer would essentially just be 2.1. Does that make sense to everyone or no?
Yeah, it does.
So that's the extent of your math on this. So really, that's probably the hardest one right here. The rest of them aren't that bad at all. So I wanted to do that with you real quick and make sure you guys have that. And then the last thing I want to go over with you guys is just a little bit about heart failure. And I'm not going to pull up a PowerPoint because that was ridiculous earlier. That thing is way too long. So I have something else I'm going to pull up. Okay, so this is the rest of what we'll do, and then we'll get off here. So heart failure. This is from this registered nurse RN stuff. I figured she kind of makes it a little simpler, so we'll just do it that way and get through it a little quicker. All right, so basically when someone has heart failure, it's because your heart is not pumping efficiently anymore. So maybe it's worked so hard because of something or other that now it just isn't pumping like it should. So your heart's too weak and it can't pump the proper cardiac output to maintain the needs of the body. So now your organs and tissues are going to suffer because you have decreased blood flow. And so she says the pressure in the heart increases, which overworks the ventricles, and the body can become congested with fluids as a result. And this can cause life-threatening complications. So some causes of heart failure then. So some of the things would be, and she says maybe if you remember this mnemonic failure, that maybe that would help you. So faulty heart valves, that could be a cause of heart failure. So you know how we have valves that are designed to let blood flow go one way. Well, when you have a messed up valve, instead of blood flow going one way, now it's like regurgitating back the other way. And so it causes problems because of that. Also, you can have stenosis or valves that are like make things narrower. So that could be an issue. Arrhythmias is another thing. So there's a ton of people out there who have heart arrhythmias, things like AFib and tachycardia and stuff like that. So if you have a heart arrhythmia, that can cause your heart to fail as well. MI, like we talked about earlier. So if you had a myocardial infarction, that can cause you to have heart failure. So that's another thing. Some people, unfortunately, just get it as being part of their family history. So that could be a problem for someone. And then if you have uncontrolled hypertension, so if you don't take care of your blood pressure over time, this can lead to stiffening of your heart walls. It causes your heart to work harder, and it can cause your ventricles to become stiff. So that could be something. Drug use can also cause heart failure. I have seen this before, and it's horrible. So people have such bad drug use that they end up screwing up their heart, and like they're young and they have heart failure. It's horrible. And then also viruses or infections can sometimes attack the heart muscle and actually cause you to go into heart failure. So that's some of the reasons why you would have it. And then remember we said there's a couple of different types of heart failure. So you have left-sided and right-sided. And then sometimes you'll see people talk about systolic or diastolic. So for our purposes, we're probably going to focus more on the left and right-sided heart failure than systolic and diastolic. So with left-sided, this is what you'll probably see most often in people. The left side of the heart can't pump the blood out of the heart efficiently, so the blood starts to back up into the lungs. Usually, if you have left-sided heart failure, it can actually lead to right-sided heart failure, so then you would have both. The left ventricle becomes weak and it doesn't squeeze blood out properly, so the heart failure can either be systolic or diastolic. And it talks about ejection fraction here. So What's an ejection fraction? Ejection fraction is just the calculation used to determine how bad your heart failure is on the left side. So a normal one would be 50% or greater. So when you see someone that has a 15% ejection fraction, you know that they're having issues. So this just means that more than half of the blood that fills into the ventricles is being pumped out. An ejection fraction can be measured with an echo, a heart cath, or a nuclear stress test. So they can do it any of those ways. An ejection fraction of 40% or less is diagnostic of heart failure. All right, when someone has diastolic heart failure, the left ventricular dysfunction, the diastole is the filling or resting phase of the heart. So in diastolic dysfunction, the ventricles are too stiff to allow for normal filling of blood. So there isn't an issue with contraction, but filling. All right, so the left-sided heart failure, you know, if you have that, most of your symptoms are going to be more pulmonary related. So like you'll hear crackles and shortness of breath and all that kind of stuff. With right-sided heart failure, when you get that, now the heart can't pump the used blood it received from the body efficiently, so it gets the blood backed up to the lungs to get replenished with oxygen, and it causes blood to back up peripherally. So now you get a backup of blood into your legs, your hands, your feet, and your abdomen. So this person, typically you'll see a lot of swelling going on with them. So some other things you might see, like this is talking about hepatomegaly. So that just means that your liver is enlarged. So because all of this blood is backed up, that's why your liver gets enlarged. And then you could see like jugular vein distension with this, stuff like that. Right-sided heart failure is usually caused from the left-sided heart failure. And then other causes would be like pulmonary heart disease or cor pulmonale as a complication of pulmonary hypertension or COPD. So I don't know if you guys remember when you talked about COPD, when you looked at that stuff, that is a big time complication that you can have from that. Okay, so again, when you think of signs and symptoms of heart failure, when you're thinking left-sided, you're thinking more pulmonary, right? So remember drowning. So difficulty breathing, rales or crackles, orthopnea. Do you guys know what orthopnea means? Are you familiar with that term? Orthopnea just means that you cannot lay down flat to sleep because you're so short of breath that you can't stand it. So you have to sit up to be able to sleep because it's so bad. Weakness is another thing that would go with this. Nocturnal paroxysmal dyspnea, so waking up in the middle of the night being really short of breath. Increased heart rate, a nagging cough, and then gaining weight from the retaining fluid. So you would see weight gain with left-sided. With right-sided, you're going to see more of that swelling. So think of swelling as your mnemonic. So swelling of the hands, legs, liver, and abdomen. Weight gain, again, so another thing that's the same. Edema, the enlarged neck veins, so the jugular vein distension. Lethargy, irregular heart rate, nocturia, and girth of the abdomen increasing, so like ascites. Okay, so things that you would do to diagnose heart failure. So there is a blood test called a BNP. So it stands for B-type natriuretic peptide. This is a blood test that shows how bad your heart failure is at the time. So it's a biomarker released by the ventricles when there's excessive pressure in the heart due to heart failure. So sometimes you'll see people with super high ones and you'll be like, oh my gosh, I can't believe they could even breathe. It's so bad. Other things that you would do to diagnose this, you probably would do a chest x-ray to, rule out other things, an echocardiogram, because remember that's an ultrasound of your heart and it's going to show all of those structures and how everything's working. You could do a heart cath. If the echo didn't show you enough, maybe you would want to do a heart cath to see more. And then the nuclear stress test could also be something you would do. Heart failure can be acute or chronic, and it can be triggered or exacerbated with things that people do, like taking in too much salts or taking in too much fluids. If they get an infection, or if they get AFib or renal failure, some of those things can cause them to have an exacerbation. So that's part of it, and let me show you the other part. Okay, so the other part, this just talks a little bit more about some of the things that you would see in interventions and stuff. So with assessing someone with heart failure, so you want to know if they have worse symptoms at night compared to the day. You want to know if their symptoms have gotten worse over a short period of time or a longer period of time. You want to know how responsive they are to medical treatment. So you're going to watch their heart rate, especially if they're on digoxin. Digoxin is a medication that a lot of people with heart failure take. You want to watch their blood pressure, because vasodilators that sometimes they're on for their heart failure can cause low blood pressures. And usually they're going to be on diuretics. So you are going to watch things like intake and output, their weights every day, watch their electrolytes, and especially their potassium. Sometimes people will be ordered to have a Foley catheter because they're going so much from the diuretics they're on. Normally, we try not to put in a Foley unless we absolutely have to with people, so that's probably not all the time. Usually this person's going to be really restricted with their salt intake, so they're going to be on a cardiac diet. Sometimes their heart failure is so bad where they have to put them on a fluid restriction. So they may be on no more than 2 liters of fluid a day. Labs that we're watching, not only are we watching that BNP that we learned about, but also their kidney function and their cardiac enzymes, including the troponin levels, their electrolytes. We're looking at all of that stuff. And especially if this person is on digoxin, they can be toxic with that. So we're going to watch digoxin levels to make sure that they're doing okay there. With the edema in their legs, we want to help them keep their legs elevated as much as possible. And then because they're so short of breath, we want to keep them in a high Fowler's position because that's going to help them breathe better. And then with safety, if they have problems with orthostatic hypotension, we're going to want to get them up slowly, dangle their legs at the bedside before we, get them moving. They're going to be at risk for falls from these fluid status changes, especially if we're getting rid of a lot of fluid, with diuretics. As far as education goes, we want them to know what early signs and symptoms of heart failure exacerbation look like. So if they start to get super short of breath all of a sudden, or if they get a weight gain, or if they have orthopnea, those should be red flags to that person to know that they're having a problem with their heart failure. The low salt, we want usually 2 grams. She has 2 to 3 grams here, but every time I ever saw anything, it was always 2. Fluid restrictions, again, sometimes it could be even more of a restriction than what she has here. This person would also want to make sure they're up to date on their vaccinations so they prevent illness, because an illness can set them into an exacerbation. So make sure they get their annual flu and pneumonia vaccines. They can do some exercise, but just do it as much as you can tolerate. Daily weights. So with the daily weights, they are supposed to weigh themselves every morning when they get up after they go to the bathroom, right then and there. That's the first weight of the day. So you're supposed to watch for no more than 2 to 3 pounds of weight gain per day and 5 pounds in a week. So if you see that, that's a problem and you would need to call your physician. We need to talk to them about being compliant with their medications. So a lot of people don't like to take a lot of medications, or they have side effects, so they just quit taking them. We need to tell them how important it is to do that. Smoking, you want to see if you can get them to quit smoking if at all possible, and limit their alcohol intake. With the medications, there's quite a few that they can be on. So know the drug categories of ones that they're on, because it's going to help you be able to remember things a little bit better as far as side effects and stuff. So the mnemonic that she has here is always administer drugs before a ventricle dies. So ACE inhibitors is the first one. That's the first A. So again, ACE inhibitors always end in that PRIL. So you can kind of pick them out that way. And usually they're first line treatment for heart failure along with beta blockers. So usually you will see them on both. This works by allowing blood to get to the heart muscle, which allows it to work easier. Also, it blocks the conversion of angiotensin 1 to angiotensin 2. But there's our side effects here. Remember, we talked about this earlier today. So you can get a dry, nagging cough that can really be ridiculous. You can have an increase in potassium, and you can also have that angioedema like Gloria was saying earlier. It's not like a super common side effect, but you can have it, so that's something to watch out for. The next category is ARBs. That's the next A. So this is angiotensin 2 receptor blockers. So these will end in the sartan, S-A-R-T-A-N. So losartan, valsartan would be in this group. If someone is on an ACE inhibitor and can't tolerate that for some reason, this is usually the next thing you would go to. What this does is it blocks the angiotensin 2 receptors that cause vasodilation. It lowers the blood pressure and helps the kidneys to excrete sodium and water. So side effects of this would be increased potassium levels, and also no dry, nagging cough with this one, which is great. Diuretics, so that would be another one. So most often, everyone's on a diuretic. So you can use these with ACE inhibitors and ARBs to decrease water and sodium retention, which will decrease edema in the body and in the lungs, and it makes the heart pump easier. So patients will urinate a lot. So loop diuretics like Lasix or furosemide can cause potassium levels to go down, so you have to be careful with that. And then there's also potassium sparing diuretics like aldactone that can cause hyperkalemia, so you would have to be careful with that. When someone's on a diuretic, you want to make sure that they take it in the morning and they don't take it at night, because they're going to be up all night peeing otherwise. So you need to make sure that they kind of understand the importance of taking it and make sure they take it early on in the day. If for some reason they have to take it twice a day, you want to do the second dose kind of early in the afternoon so that you're not up all night. So maybe like 1, 2 o'clock. Okay, beta blockers. So these would be like your LOL type drugs, so metoprolol, carvedilol, that type of thing. So usually these are given in stable heart failure patients along with ACE inhibitors. They block norepinephrine and epinephrine effects on the heart muscle. They're not for acute heart failure because the negative inotropic effect of the heart. It can decrease myocardial contractility and slow the heart too much. So you only want to use it in stable heart failure patients. Side effects, you can have bradycardia. This can mask hypoglycemia incidents with diabetics. And if you have respiratory issues, it can cause bronchospasms, so you have to be real careful. Anticoagulants is another thing that people can do when they're on heart failure. So usually this would only be if someone has like an arrhythmia that caused their heart failure, typically like AFib. That would be more so why they'd be on this. Vasodilators, hydralazine would be an example. Sometimes this will be prescribed with a nitrate like Isordil. Sometimes this can be used in place of an ACE or an ARB. Side effects would be low blood pressure and orthostatic hypotension. And then digoxin. Again, remember this has to have that certain level in your system. So if you don't have enough of it, it's not going to do what you want it to do. And if you have too much, it can be toxic. So this can cause your heart to beat slower. And usually this is used for treatment for patients with left ventricular systolic dysfunction. Usually it's used alongside an ACE or a beta blocker and diuretics. When you're toxic with digoxin, you can also have a problem with your potassium. Like if someone has a low potassium and they're on digoxin, you want to make sure you treat that potassium right away because it can cause toxicity if that's the case. Some of the signs and symptoms of toxicity, think like GI type stuff. So nausea, vomiting, and then think of your vision. You can have yellowish, greenish halos around everything that you see. So it's like a vision issue. So normal range of digoxin should be 0.5 to 2. So if they're above that, that would be toxic. You always want to check the apical pulse before you give it. So if their apical pulse is less than 60, you would hold it. And then there is an antidote for this. So the antidote is Digibine. So again, you guys, I would encourage you to look at your ATI MedSurg books because I think those will help you quite a bit with some of these topics. This weekend, I want you guys to make sure you go through my things to know, see if you have any questions about that. I'm trying to think when we could get together to do some kind of review before the test. What's your thoughts?
That's all.
What's that?
I'm good any day
What?
except Tuesday.
Oh yeah, me too.
Any day but
Oh, same
Tuesday, you said?
Yeah,
So-
any day but Tuesdays for me too.
Okay, so if I did it in the evening sometime on a different day, you guys would be okay?
Yeah,
Yeah.
as long as it's before 7 p.m., it should
Okay.
be fine.
Okay. I'll see. I know I have a meeting on Monday, and I'm meeting with another student that day, so I can't do Monday. So it might be like maybe Wednesday or something. We'll see if we can do. So
Okay.
that's
When's they're on campus for lab? I think
till when?
like 5.
Okay. Well, if that's, I mean, I could do it. Well, maybe we could do Thursday even. I don't know. We'll figure something out. If you don't want to do it on Wednesday because of that with lab, I could probably do Thursday.
Okay. Thursday after 1, if possible.
All right, we'll figure something out. I'll put out a Zoom invite for that once I figure out
Okay.
the exact day and time, okay?
All right.
All right, any other questions or anything?
Mm-mm.
Okay, I will see you guys later. Thanks for coming.
Thank you.
Thank you. Have a good day.
You too.